Well, good morning, everybody, and thank you for joining us. My name is Daryl Gordon, and I am Vice President of Marketing at MediKeeper. And I'm going to do just a very few quick announcements because I know that everyone's as eager to get into the content as I am. The session today is being recorded, so there's absolutely no reason to take any notes. It'll be available up on our website in just a couple of days, and you'll be able to download this session as well as all of the others. If you have any questions, you'll notice at the bottom there's a chat functionality, and you can submit your questions to our two presenters today. And if we don't get any of your questions or all of them, we will definitely follow up with you afterwards. So to conduct today's session is Dr. Tyler Amell, who's the Chief Health and Strategy Officer at MediKeeper. Dr. Amell, I was looking, and we first started this session back in March of 2021, and this is our 38th webinar. We've had some really outstanding speakers throughout the series, and today is definitely no exception, but I'm going to leave the formal introduction to you.
Great. Thank you so much, Daryl, and good morning, everyone. We really appreciate you taking time out of your busy schedules to join us here today. This session is very much focused in on metabolic health. This is something that's a topic that's near and dear to my heart, as well as a lot of other folks, including our very special guest star today, who's been a colleague of mine for years now. Mary Beth, trying to think back to the first time you and I had a conversation was probably about 5 years or so ago, originally. And then, of course, we've kept in touch over the years, and we're quite happy that you're able to join us here today. So it would be great if you would introduce yourself to the team, maybe give a little bit of background of who you are, and then I'll cover off myself as is customary, and then we'll get into the content.
Sounds good. Thank you, Tyler, for inviting me. I'm super excited today. My name is Mary Beth Torres. I am the manager for the Team Member Health and Wellbeing Program at Baptist Health of Jacksonville. I am a registered dietitian by trade, and I've spent 25 years of my career around weight management and metabolic health. So I'm very excited to have more of a conversation and really talk about this because 25 years ago, we knew very little, and now we know so much that can really help our people really drive to the success that they're looking for. So excited to kind of share some of our outcomes and what we're doing at Baptist.
Absolutely. You folks are doing some great things from an innovation perspective. That's something I can't wait to hear more about. On my side, as Daryl mentioned, I'm the Chief Health and Strategy Officer at MediKeeper, but like many of us these days, I wear numerous hats. I'm on faculty in the Registrar at Pacific Coast University for Workplace Health Sciences. I also sit on the board of directors for the Wellness Alliance, and many of you may be familiar with that organization. I'm the Secretary Treasurer of that group. And in fact, next week, we're getting together in Nashville for the Wellness Summit. And so the Wellness Alliance is comprised of, Historical National Wellness Institute, WellCOA, as well as the newest addition to the team, the Wellness Council of Wisconsin. And so, we continue to aggregate and bring in experts and thought leaders and great membership from across the country. So we're quite pleased with that. My contact information is up on the screen. Please feel free to reach out to me on LinkedIn. I'm very active. I promote a lot of evidence-informed practice and applied research when it comes to workplace health and productivity. Super happy to hear from you, reach out and help spread the good word about all the research that takes place in this particular area. So speaking of this area, I was actually speaking at an event in Portland last week on innovation when it comes to hypertension and type 2 diabetes and some of the neat things that's happening on the technology front, on the behavior change programming front, and a few other things like that. And so this presentation is exceptionally timely from that perspective, right, Beth, because it sort of feeds into what you folks are doing at Baptist with regards to where things are at. But prior to getting into that, I just wanted to reiterate the severity of the problem here. Now these data are from the CDC and a few other sources. This is the prevalence of chronic diseases in the U.S. by specific chronic disease type. Now, the ones highlighted in yellow are the ones that are related to metabolic health and metabolic syndrome, metabolic disorders. The lower number is the healthiest state, and the upper number is the unhealthiest state. So these are quite significant. So if we look at hypertension, this is high blood pressure. The healthiest state has about 30% of the population that's impacted by high blood pressure. The unhealthiest has about 39%. Obesity, very similar rates in there. High cholesterol, similar rates in there. And diabetes sitting at around 9 to 13%. Now, what's quite interesting about diabetes is this has been an area that we've been focusing on, particularly from a GLP-1 perspective. I know you're going to share some of your thoughts on that, as well as a few other pieces. But when you begin to unpack the impact of diabetes, you begin to really understand how much this drives things. Like we know heart disease is the number one killer of people in the U.S. Many cases are preventable. Same with diabetes. In fact, most of the cases, upwards of 80% of type 2 diabetes cases in the country are in fact preventable. But from a holistic sense, this is contributing to about 100,000 deaths per year and about 400,000 if you look at contributing causes for deaths. And this is based upon death certificate analysis. And that's, these numbers are staggering unto their own. But, when you unpack the incidence rates and prevalence rates, so incidence is the number of new cases per disease per unit time, and prevalence is how many people have it at a given point in time. So the incidence rate for diabetes in the US is about 1.5 million people. Okay. So this is a big number unto itself. We got about 40 million people living with diabetes. We have about 11 people wandering around out there who are undiagnosed. But the biggest number from my perspective here is the pre-diabetic population. So here's this very large, this is 115 million people. This is, upwards of a third of the entire population, which sort of goes back into some of those other numbers that I saw. So we're dealing with some big issues here. And so this is top of mind for a lot of folks to realize that. And, this is one of the reasons why I wanted to have Mary Beth on here, because she has, great experience throughout her career and is currently at Baptist Health in Jacksonville, and some very interesting things going on there from a programmatic perspective and an integrated approach to solving this problem. So I think, Mary Beth, my first question to you is, would you mind describing your target metabolic programming? Like, who are you supporting? Is this for Baptist Health employees and employees only, or is this for businesses in the area, or is this a combination of them both?
Yeah, so for my team, our wellness program, we target our team members. So we have about a little over 16,000 team members. But we also support their spouses and 18 plus a year of age dependents. So if you really look at it, it's not just for the medical plan, it's everyone. So we have at least 22,000 people that we support. We do have a wellness program, and it does provide a lot of the same resources we have for the community and the local organizations here at Baptist, named PATH. So I think we not just take care of our people at Baptist, we're also really targeting and taking care of our community.
Oh, excellent. Now of those folks, what's your participation rates? Like, how many are you actually getting to speak to? Because ideally, if we just use the numbers that we talked about, if it's 22,000, we'll say 30% of that, just to be certain, the Florida
Yeah.
numbers are a little bit higher. They're probably 35%. Does the numbers work out that way, or can you describe, the actual numbers of folks that you're supporting on a programmatic perspective?
Yeah, no, we actually have so many people that come in at different points in our program. Our metabolic health program, we actually integrate it in so many different ways. I'm going to touch more on our coaching program because I think that's where we've really created a multidisciplinary approach, but also different learning styles that make it very um, easy and accessible for our team members. So typically, I mean, here's the reality. We have an unrealistic idea of how many people are going to engage in our program, right? So we hear all the time we're in wellness is like everyone should be participating, but really, if you look at a lot of evidence-based science, even with a lot of the GLP-1 articles coming out, typically 3 to 5% of your employees will engage, or 3 to 5% of the population will engage in coaching services, right? So at Baptist, as we have continuously layered different resources for our team members, and availability, we've seen a 68% increase in participation year over year since 2024. But the most impressive piece is we just don't look at participation, we look at engagement. We have 54% of our team members who are engaged, and they're working with us more than just once. I mean, you move the needle, you make an impact when you get them coming back, and then finding different ways to integrate into the system and participate into different wellness services. Because a lot of times we have a focus that it's a one intervention. It's a one and done, one intervention. We tie to so many different interventions to it. And then, of course, we survey our team members, 99% satisfaction rate when it really comes to our participation rates and our coaching services.
Well, that's great satisfaction. It's kind of one of those questions, would you recommend this service to somebody else is a really good measure. And I'm guessing at 99%, you probably get a pretty high referral rate. So
Yeah.
can you describe to me, how you folks ended up designing your programming? Is this a research-based sort of approach where you look at the market, you see what everybody's doing in the space, you try and do that, and then obviously through constant iteration and changing and tweaking and a little bit of applied research, you came up with this sort of integrated approach where you're looking at condition management as well as the prevention side. Or I'd love to hear how you folks actually designed this program from the ground up.
Yeah, so we took kind of a two-prong approach. First of all, when I came to Baptist in 2020, I went out and I just talked to our team members and understood what they were really wanting. And then I also use our health risk assessment annually to really listen and hear what they're looking for. Of course, weight and weight loss is always the number one focus. However, at Baptist, we are a healthcare company. We have a rich resource and robust knowledge and expertise here at Baptist. So how we designed our program is utilizing those robust knowledge, and knowing we have Baptist providers, we also are looking at that multidisciplinary approach. So we moved into the space of we got to find we have the right people in the right program delivering the right type of resources. So number one, we brought dietitians on our team from a nutrition standpoint. We have certified personal trainers from a fitness and making sure, especially as we're talking about GLP-1s. And then we also have a certified mental health counselor, or kind of that life coaching. The psychology and mental health piece is such a huge component that it tends to be a missing component. But we also leverage our behavioral health, our EAP programs, and we leverage our behavioral psychologists. They're not in our wellness program, but we do leverage them in order for our team members to have that great experience. At Baptist, we have our primary care physicians. We also have a metabolic weight loss clinic that just started about a year and a half ago. And we have a bariatric surgery program. So we've created a really wraparound, comprehensive program where people can come in and self-select to come into working with our coaches, or they can be referred by their physicians, and the physicians can refer for coaching services. And honestly, we do really our programs are based out of a foundation of lifestyle medicine. We're a healthcare company, right? Lifestyle medicine is not a one-prong approach. It's a multidisciplinary approach. You got to focus on all the different lifestyle pieces. You can't just focus on one. If we're just focusing on weight loss and just focusing on a nutrition intervention, we are not serving and giving that patient or team members the right access and the right resources. This journey is lifelong, and it's a multi-prong approach.
Excellent. And I really appreciate the fact that you folks are bringing, the psychological aspects of that as well, because that's absolutely critical. And, when you think back to sessions that I've run personally, and I do a lot of training for International Foundation of Employee Benefit Plans, and I do a lot of retirement planning for folks. And I ask them what their health goal is, and 95% of the people say weight loss is number one on their list, and rightfully so in many instances. But there's so many factors that go into it. Now, I noticed that you brought up the notion of multidisciplinary versus interdisciplinary. Now, typically speaking, multidisciplinary is you throw a whole bunch of different approaches to it without actually truly integrating. And then interdisciplinary is using those same sort of multi-pronged strategies, but actually integrating the findings. And this is where I know that you folks at Baptist are actually doing it. So it's not just you're ticking off a whole bunch of different services off the list, but you're actually integrating them. And that's where I think you get the bigger bang for the buck when it comes to an outcome perspective, is because the psychologist is actually speaking to the dietitian, who's speaking to the person who's managing the GLP-1s, and, deciding whether or not we're going to progress into a bariatric intervention, which is, worst case scenario for a lot of folks, but very effective. Meanwhile, we've got a whole bunch of other folks over here. And so you're balancing all these from a lifestyle medicine perspective and from an overall integrated health perspective, which I think is absolutely wonderful. So let's talk a little bit, and you and I have had a few conversations around body composition, and this comes up all the time.
Yes.
BMI, body mass index, everybody knows it. You should know the numbers if you don't. If it's between 18 and 25, you're in a healthy zone. The higher the number above 25, the worse the scenario is. Now, BMI is not the best measurement out there whatsoever. This is a relationship to your height to weight. But because we've used it for so long, and we can use it across the globe. So we've got tons of data globally on all this. So, it's very effective. You don't need $100,000 DEXA scanner like you folks have several of. But this is what makes you folks different, because you're going beyond BMI, and you're going beyond that crude metric, if you will, although crude, but useful because of the research side. But knowing that you can go much deeper into body composition and then layering in those other pieces. I'd love to learn more about your approach to that and how you're actually integrating in all these different pieces as well.
Yeah. So I've been very fortunate in my career working in corporate wellness, where we've supported kind of having that data. So, old school was bod pods. They're just super uncomfortable. No one wants to put a shower cap on. But it gives really good data, gives you understand information, helps you make an informed decision, right? Everyone is a unique individual. If they don't have that information, they don't know where to move forward. So in 2022, we noticed that Sika had put out a new body composition assessment that's a medically graded. It measures on muscle MRI studies, not compared to DEXA. So it does have a better standard error than some of the other, like bathroom scales or the other body comp resources. However, our body composition assessments have been a huge component to be able to help people move in the direction of the intervention that works best for them, or with their journey. Think from a behavioral, we can really focus on one thing at a time. So from the body composition assessment, they can break down skeletal muscle mass, body fat, and are we losing body fat over skeletal muscle during the weight loss process? Is the weight loss healthy, or is it driving more inflammation? We can get that from this as well. It does get, and also, is it extracellular water, total body water? How are we doing from a hydration standpoint, which we know is so essential when it comes to metabolism, right? So we use that as a way to help them measure. And honestly, that has been one of our most popular, I don't want to say services, but people have used that to really kind of understand what their next step is in that journey. We are very direct and honest with people, that we tell them it's important that you understand this, because we do have people with BMIs of 28 who come in who have optimal foundation of skeletal muscle, their optimal visceral fat, and their optimal body fat. In that way, where's their A1C? How's their hypertension? There's their blood pressure, cholesterol. All those numbers are great. So we really kind of shift a lot of our conversation. It gives us the opportunity to shift our conversation away from weight loss to weight health. And a lot of the people who come into our coaching program are also females who are high women, with nursing. We have a lot of nurses that are in perimenopause and menopause. So we have a lot of good conversation, and we're able to shift people away from just health as the destination of their goal, and we're able to help them kind of drive around different interventions. And weight loss is never linear, right? It's this up and down hurdle. So we really kind of, I think we spend more time shifting away from the weight conversation and more into the weight health conversation, or as we know, metabolic health.
Right, which is an absolutely excellent way to frame this conversation. Now, and I love the fact that you folks are incorporating the Sika scans. I myself, I use some impedance scales as well to test them out. I've tested out the Garmin and a couple of other ones, and it's great. Not as clinically accurate as the services that you folks are able to provide, but great for those intercessions between between your interventions and your meetings and that sort of stuff. So great way to do that sort of thing at home. In terms of technology elements, like how are you supporting the integrated data elements in here? Like how are you leveraging tech to sort of manage and then produce the outcome reports and those sort of things?
Well, I never thought as a dietitian I'd be as familiar with technology as I am. So I will tell you, people like in person, but after COVID, we've really gone into the virtual space. And also at the same time, we have a 24-hour workforce. So we have to be very conscious about how people are absorbing the information and access the information. So we leverage technology to really help people have opportunity to educate and engage at their own pace. So we use, our wellness portal in order to do that in their coaching portal. However, we also leverage technology in order to communicate back and forth with the providers and the physicians through Epic, our EMR system at Baptist. And then we also are using the technology with the Sika scans. Those are all integrated on the back end. From an administration standpoint, we have to be super knowledgeable, but we've created a seamless experience for our team members to engage in all the services that they feel are most relevant for them. The Sika, and even we're using continuous glucose monitors. So CGMs are an opportunity where our team members, if they have prediabetes or elevated blood sugars, they have an opportunity to utilize CGMs and then work with our coaches to understand where their next step is and how their body, the hormone levels are working, right? We know so much more about hormones, and we know that what's interfering and what's not. And it's something we've never had opportunity to really kind of dig in and help people from a behavioral perspective.
Right. Excellent use of a lot of innovative technologies. One of the things that I've been speaking about recently is the use of a facial scan on your smartphone in between visits. So, without having to break the skin and actually being able to measure with relatively strong accuracy, hemoglobin A1C, blood pressure estimates, these sort of things. So there's some very cool things that are happening on that front. And when we get to true real-time CGM, like that's going to be interesting because, there is a bit of a lag between the CGM's measurement values and when the blood sugar is changing. So once we get to that
Sign
true
me up.
real time, that's going to be very
Sign
cool.
me up.
I understand.
I'm always.
I understand FDA is working on approving some of those, but that's going to be interesting. So now let's talk outcomes. I know we're coming up on time here. Like we could go on for a long period of time. This is the part that myself as an epidemiologist, I really love to see what's moving the needle here. You cited some really good statistics with regards to participation and engagement and people being satisfied with the service. But let's talk some outcomes here, Mary Beth, because I know you have some great ones.
Yeah, no, I mean, and another way of how we design the program, and I think this is a good segue into the outcomes, is that we have to support what the organization is looking from a benefit design standpoint, right? So GLP-1s is a hot topic. The cost is the biggest driver around decisions. But I think if we can look at the outcomes that are related to, and we can tie back in as wellness programs, we are tying interventions to help our HR benefit design achieve the outcomes they're looking for. So there has to be that partnership there, and we have to be ones collecting those outcomes. So yes, recently, I can't say hot off the press, but a little hot off the press, we've been kind of evaluating this information, right? So, and we're all about this is only measured. We don't take any self-reported, but all the measured. So if we have someone who's done at least 2 Sika body scans, we include them in our outcomes. So people who are taking GLP-1s, what we found that in an average 6-month program, they're 94% of them are achieving that 5% weight loss, right? So we know that there's a clinically advantage with a 5% weight loss. But at 6 months, we also are seeing more than 30% are achieving more than 20% weight loss. And now these are people only who are engaging in lifestyle intervention in conjunction with the GLP-1s, not just GLP-1, right? So we need to know, and we need to make sure that we educate people around making sure that everything is a tool, not one intervention is a solution. And that is a driver conversation that's important. Now, body fat change, we've seen 5.8% change in body fat within that 6 months, and only 13% change in muscle mass. You hear all the time about significant muscle loss. We only see 13% because people are engaged. Now, the goal is less than 25%. So when you see these 40%, that's great. But we've also seen a significant change in the visceral fat and also a reduction in A1C by 1.2%. That's a huge number. If you say 1.2%, someone could start off at that pre-diabetes range, right? The 6.0, and they could lose it down to 5.2, which puts them from a pre-diabetic to a non-diabetic normal range. Our lifestyle and, GLP-1s we know have greater outcomes, but our lifestyle, we've seen about 34% of people at 6 months achieve that 5% weight loss. And then about 10% can achieve over 10% weight loss. But we've seen a change in body composition like body fat. So 1.2% body fat, and then only a 5.8 change in muscle mass. So the lifestyle intervention is really making a difference. And it's actually the driver of success and optimizing outcomes.
Yeah, and I agree 100% with that, Mary Beth. And thank you for sharing those data elements. That's exceptionally powerful. Because one of the things that obviously we want to do is to get people off of GLP-1s. These are very expensive drugs. Everybody could benefit from them to a certain degree, but we can't actually have your entire population of 16,000 people and your dependence on those. And with the goal being, maybe use this as an acceleration to help with behavior change in conjunction with all the other pieces. But then you have to remove the drug at some point, which is where the lifestyle components really kick in. So I suspect that that's really going to drive more sustainable outcomes for longer periods of time, assuming that people can make those changes and then actually have that as part of their new self or their 2.0 version of themselves.
Right. Well, and we have to look at too. So some of the future outcomes that we're looking at is comparing the two groups, right? A diabetic versus a pre-diabetic and a non-diabetic. We know that the insulin and a lot of the hormone shifts, diabetics are going to lose less weight. It's just that's the reality. So we are going to be getting more in depth around, the type of person, the individual, rather than putting him in this bucket. And then those who are just using a medication therapy or just a surgery as their tool or solution compared to those that really kind of have a foundation of lifestyle.
Excellent. Well, Mary Beth, I would love for us to be able to go on all day. Unfortunately, we can't. I thank you very much for your time and attention today. I'm going to turn it over to Daryl, and hopefully we'd love to have you back again in the future as well, Mary Beth. It'd be great.
Thank you.
Absolutely. Well, as we suspected, we would run out of time very quickly. So we're not going to get to the questions today, but if our speakers don't mind, I'm going to send those questions to you to answer directly to our attendees today. Thank you both for your time. Thank you, everyone, for joining us. This will be available on our website in just a couple of days. Thank you. This concludes today's session.
Thank you all. Make healthy choices.